At the moment, you have about 20% of the population of the countries worldwide are using almost 90% of the available morphine.
Welcome to Transmission, the podcast of the Institute of Tropical Medicine in Antwerp. This season, we invite you to join our researchers in their never-ending quest for a healthier world. In the previous episode, we discovered we cannot take our health system for granted. But even if it functions, you need to be able to access it. So in this episode, we will discover why access to healthcare is something worth fighting for. Transmission, your front row seat to the world of health, science, and beyond. Imagine, you and your partner are about to have a baby, and you need to get to a hospital as quick as you can. You're both in the car, but it's not speeding to the clinic. In fact, it's not moving at all. You're stuck in traffic. As your worries mount, you realize you will never get to the hospital in time. A crisis does not always have to be as big as a global pandemic. Sometimes it's trivial things, like structural traffic jams on the way to the hospital and a mother giving birth in distress.
When women cannot get to that advanced care, they will be dying in transport or not even reaching that facility.
Lenka Beňová is a researcher at ITM's Reproductive and Maternal Health Unit. Together with partner organizations, she works on improving maternal health care. We already met her in the first episode. After the death of a woman, the hospital will typically organize a maternal death review to see what went wrong, and the responsible committee will take notes.
And so you will find maternal deaths, records, files, which will say dead on arrival or, died shortly after arrival. So when it comes to the maternal death review, that committee will say, well, there's nothing we could have done. This woman was already arriving in such a state, we couldn't help her. But it's not our death, they will say.
It's not our death. It shouldn't be on our list. It's not up to the hospital.
And they are right to some extent. But it is our death in terms of a system, in terms of a society. And so these linkages, whether it is traffic or money for transport or ambulance prioritization for maternal cases, are going to lead to deaths, perhaps the worst deaths of all, which are unaccounted for.
How does Lenka cope with the fact that this should have been a preventable death?
Well, we wake up angry every day. That's the way you get going, right? You wake up and there is this huge injustice happening, whether it be for lack of political priority, lack of funding, due to conflict and displacement, due to racism or socioeconomic marginalization. So we fight on and we do our research. We try to communicate it and push ahead. And, luckily we are not the only ones. There is a large community of researchers and implementers around the world who are all doing it. But that's what you have to, you just have to believe that things are improving slowly every day.
It's not only that getting access to a good hospital might be impossible. Getting the medicines you need is not always a matter of strolling to the pharmacy either. It is war. You sit exhausted on a chair, holding your last insulin shot. Soon you will have to go out again to find medicines to treat your diabetes or your epilepsy. But where do you find them? Outside is chaos. Access to medicine is gone. The pharmacy you used to go to is in ruins. And the NGO that helped you with your care has left the country. The fact that non-communicable diseases such as diabetes and epilepsy are particularly challenging during a conflict is no surprise.
Globally, non-communicable diseases are among the most common reasons for mortality, and these are neglected in conflict zones.
It is a gripping story that ITM researcher Saleh Aljadeeah, who we already met in the first episode of this season, heard from a patient in his home country of Syria. But even if you find a place that still sells insulin, you're not out of the woods yet.
On regular basis, the issue in the place where he lives in northern Syria, that in summer temperatures reach 40 or even exceeds 40 degrees. So storing insulin is challenging in these settings, especially at the same time you have electricity cuts.
The question is not just whether you can keep insulin cold in a 40 degrees centigrade environment where the electricity is constantly cut and bombs are exploding. It is also whether the person you are buying it from has done so. What happens to the supply of medicines when war breaks out in a country? It is Saleh's quest to better understand this. Driving a truck through a conflict zone is not easy, even if you leave out the bombs and armed troops.
So checking points, you see, at the border, sometimes the medicines are held for a long time to kind of get the permission, but also the security issues, like you are waiting, let's say, with your truck for a time when the bombardment is kind of less severe, or sometimes you have cut-off bridges, so you cannot move forward.
If the truck is delayed over and over, the medicines are getting closer and closer to their expiration dates, to the point where they are no longer usable by the time they get to their destination. And there is also something more insidious at work.
Another issue is donations. So we see that sometimes medicines that are donated are kind of close to expiry date.
Because they are donated close to the expiration date, they are expired by the time they get there. So, say you finally find a trustworthy pharmacy with an affordable drug. Even then, you don't buy more than one package.
Many patients were telling me that, well, we don't do that because it's obviously that by finishing the first package, then the second package is expired.
And even if you know a pharmacy that is trustworthy and has the medicine that you're looking for, there is one final hurdle to take: money. Is the pharmacy charging a fair price? In most countries, there's a fixed price for medicines you buy at a pharmacy.
This is not the case in a conflict zone. So each pharmacy has its own prices, and the patient goes from here to there. So they need to navigate the system to make sure that they get, let's say, the best price they can afford. But here, this is also very much linked to the quality, you know. They need also to think about the quality of the medicine. And this is a huge burden on the patient, you know, to think about, okay, is this medicine of good quality or not? Should I pay less?
Especially if you have a chronic disease like epilepsy or diabetes, it becomes a hell of a challenge because you need these medications, whether you want it or not.
This is an issue we see in conflict zones. Families who have members with chronic conditions, sometimes they need to choose between providing food or medicines.
Leaving you to sit there on your chair with your last insulin shot in your hand, wondering where you can get the next one. And money is an issue everywhere, not just in conflict zones. The year is 2016, and we are in a busy conference hall. It is filled with researchers from all over the world. A researcher from Cambodia comes on stage. He has been invited to talk about his work with people with diabetes. He taps the microphone and tells a story about one specific encounter he had. A patient with diabetes looked at him and said,
"I wish I had HIV."
Raffaella Ravinetto, head of the Public Health Department at ITM, still remembers the talk vividly.
It was a provocation, but not that much, because as an HIV patient in Cambodia, this person would have received antiretrovirals for free, but with diabetes, has to pay for insulin, has to pay for the syringes, has to pay for the glucometers, and this is all out of pocket of the person, independent of the income of the person.
The person would have been better off with HIV than with diabetes, because we pay much less attention to the non-communicable diseases like diabetes, cardiovascular disease, or epilepsy.
By the way, it's not only poor countries. Every year there are people who die in the United States because they do not have health insurance. So that from lack of access to insulin are also reported in the United States.
The forces that could keep a medicine out of reach are sometimes too vague to even imagine. During COVID, you saw rich countries start hoarding vaccines, up to the point where some of them could vaccinate every individual multiple times with all the vaccines they had gathered.
And southern countries had essentially zero vaccines.
We hear Chris Kenyon, working as a researcher and as a doctor at the HIV clinic of ITM. We know that the global north has been hoarding vaccines to the detriment of the global south.
South Africa was forced to send its COVID vaccines that it made in its factory in Port Elizabeth to Europe because of patent issues and all the rest.
Patents are a major gatekeeper indeed. The same thing happened earlier with the availability of HIV drugs.
When I first worked in South Africa, 40% of the patients we would admit would die within 2-3 days because they had AIDS and we couldn't do anything for them. And that was at a time when HIV medications were available. And so we were working in this knowledge that actually all of this was preventable.
Like with the COVID vaccinations, patents were preventing the availability of medicines. It was only when there was mass protest that these drugs became available.
And so I think that's an incredibly valuable lesson. And it was disheartening to see in COVID that we actually hadn't learned that much, that we had to go through that same process again before vaccines became accessible in the South.
Or as Raffaella Ravinetto puts it,
did we as international community learn from that experience? If we have another outbreak, global pandemic, and we will most likely have it, we know that we are able to develop a vaccine very quickly. Will we be able to deploy it immediately this time everywhere and not starting from the US and the EU and Canada? At the moment, the answer is not.
3.5 years after the start of the pandemic, we are still discussing patents and whether we should be able to open them up when the need is high.
No, we are not there, and if a next epidemics outbreaks comes and we are in the same situation that we have a vaccine and we don't know how to make it available to everybody immediately, that would be really a moral defeat of our society in the way it is organized now.
Equal access to the medicines we need is far from a given, but nowhere is it more evident than in the world of painkillers, drugs we need to operate on the sick and keep people from suffering.
There is an incredible imbalance in access to these medicines, like morphine, which are essential to treat severe pain. At the moment, you have about 20% of the population of the countries worldwide are using almost 90% of the available morphine.
There are a lot of countries in the world where they can't give you morphine to relieve pain, whether you're in intensive care with terminal cancer or you're having surgery, just because morphine is not available.
When you have a war, the needs in morphine will increase because you will have more wounded, etc. And that's very difficult for the country to get to procure this product in emergency. And we have read it recently, hospitals in Gaza doing surgery without anesthetics, so without post-surgery pain therapy, but it may be the same in Niger, it may be the same in Sudan at this moment.
Why don't we make more morphine then? For one reason, morphine is an old drug that anyone can produce, which makes it less interesting for companies. But morphine is also subject to strict regulations to prevent drug abuse, with the unfortunate result that, for example, regulations designed to prevent abuse in the United States have a very real impact on the availability of morphine in low-income countries. The system surrounding the drug is complex and involves a lot of financial, cultural and legal hurdles.
Really, if you look at this figure, you see the countries with access to morphine and the countries with no access to morphine. It looks like the colonial maps of the 19th century. You see that the morphine is in the former colonial power and not in the former colonies. This should be a scandal for every journalist around, but it's not very much discussed.
Unequal access to healthcare is not only a problem for countries in the global south. For example, PrEP, the drug that can prevent you from getting and spreading HIV, is far from available everywhere. Chris Kenyon talks about sex workers in Antwerp.
It's still not really available in sufficient quantities worldwide. There's still many populations, who don't have access. Like I said, here in Antwerp, in fact, Skipperskwartier is a few hundred meters from here, and there's people there tonight who are going to be having unprotected sex because they can't get PrEP. So it's happening here. So there's many populations that are not getting enough PrEP.
But we must not fall into the trap of pointing fingers.
When you talk about access to medicine, the discussion gets very easily polarized. We come from situations in the past when it was very easy to fight the guilty one. So, it's the industry. Oh no, it's the patients who doesn't understand. Oh, it's the government who's not committed enough.
It's never one person's problem or one person's fault.
Everybody should act to improve it. In other cases, it's more straightforward, but we should really avoid this kind of polarization.
Let's say the stars align. Everything works in your favour. There is a well-functioning healthcare system, the prices of medicine are under control, the patents are cleared. And still, you don't get the medicine. Why? Well, sometimes it is the lack of information that is keeping you from getting access. Take PrEP again. One of the people who was ready to take PrEP from the beginning was Tim de Vries.
I heard about PrEP for the first time in New York, casually at a gay bar. And I was fascinated and I didn't know what it was.
Tim is a patient at an HIV/STI clinic in Belgium. He's always on the lookout for more information. In Belgium, there are 12 clinics where you can go for HIV and STI treatment without fear of being judged. ITM hosts one of those clinics, where countless patients are helped every year. These are safe places where you can talk about your concerns.
I've been very, very preoccupied by that part of my identity. Figuring out what it means, how other people have interpreted it, how other people have dealt with it, how other people have expressed themselves. When I was growing up, sex didn't exist. It didn't exist, right? It was never part of any conversation.
But then the word was out. There was a drug that could prevent HIV infection. It wasn't yet available in Belgium until suddenly, in 2017, an email arrived in Tim's inbox. A press release from the Ministry of Public Health saying that PrEP would now be available and reimbursed.
I just saw the title and I dialed the clinic to ask if I could get an appointment and get this show on the road. So I think I was probably one of the first, because the news wasn't even out yet. I just had the email. I was probably one of the first.
When PrEP became available, Tim's life changed.
It changed it completely. I've noticed that I'm, sexually speaking, more carefree. I feel more emancipated about the choices that I make. I think it's a godsend. And I'm very, very grateful that it exists here. And that it exists for so many people. I just hope that more people who need it get access to it and use it properly and understand what this means, not only medically, but also mentally, psychologically, all that sort of stuff. It was a life changer, absolutely. Yeah.
A wonder drug. But what do we see? For a bunch of different reasons, a lot of people whose lives would be changed for the better don't take it. A lot of uncertainty and ambiguity remains. Again, researchers have to find out why people can't access the drug or don't use it. The hardest group to help are often undocumented people. It is a huge challenge for doctors to get them into proper treatment. But that's mostly because of the rules. Chris Kenyon explains.
There's a lot of people here who are not legally here, who are not entitled to HIV PrEP. And they're frequently dependent on sex work. And so both for themselves, for their own health, and for the public health, it would be logical to give them this medication that's fairly cheap, very effective at preventing HIV. And tragically, we still are unable to give all those people the medication they need to prevent HIV, which is, I think, very short-sighted as a society.
The barriers to a sexual health system that is accessible to all are many. Tim sees this happening regularly.
Well, I think there's a lot of high bars. I think health, especially sexual health, because that's the field of medicine that I, quote unquote specialize. I'm not a specialist, obviously. I'm more of a habitual connoisseur. It's very system focused. The system is central, and then the patient has to sort of adapt to the system. It's all very confusing. It's very, very confusing, and there's never like a single entry point. And there's so many different places where you can go that it becomes very diffuse and difficult for a patient to find the right info and the right help. I mean, the help is there. I am very happy with the support and the service that I and the care that I get. But everything that's self-evident to you is not self-evident to somebody else. And it's in those cracks, that's the cracks that people fall in between, right?
We leave the HIV clinic and go to Zambia, where young people are renovating a house so they can take the access to their sexual health into their own hands. A place where they feel safe amongst their peers. It's a very special house.
We wanted to create a place where young people felt like this is something for us.
HIV rates and unplanned pregnancies are high amongst adolescent girls and young women in Zambia. On top of that, young men are less likely to know their HIV status or think about family planning. That's why ITM researcher Bernadette Hensen was looking for ways to get young people between ages 15 to 24 in Zambia to think about their sexual health. Interviews quickly revealed that young people wanted a place of their own where they could talk about sex, consent, HIV, relationships, or where they could get menstrual products or condoms. They were not at all eager to use mainstream health services.
It's often that they shouldn't, quote unquote, be having sex, and yet often many of them are. And by going to the health facility for something, you're disclosing that to someone, and often someone a lot older than you. One of the things they said is, well, we don't want to go to the health facility because sometimes it's our auntie who works there, or we're in a queue with a lot of pregnant older women who know our parents. So they wanted services in their communities.
And that's why you hear carpentry. Young people have teamed up with the local organisation Zambart and Bernadette. In different villages, they build places where they feel comfortable. It's community participation at its best.
They chose the logo, they chose the colours, and then peers, a little bit, usually around the age of 20 to 24, would provide the services. And they weren't just HIV testing, it wasn't just condoms, it was very comprehensive, including comprehensive sexuality education, menstrual hygiene products for the young women and girls, contraceptives, edutainment.
The screenings of the MTV show Sugar, a television series about HIV, sexual health and consent, were wildly popular. On those nights, the building was packed.
There were lots and lots of young people there because they were very keen for knowledge, right? Everybody wants to understand things.
Bernadette's mission is to find the barriers that keep people from seeking healthcare and to break down those barriers so they can get access to it.
I'm just very intrigued by how we behave, what drives our behaviours.
Because that in turn has a strong influence on how we can improve our own health.
For me, at the heart of that is dignity. The ability for people to walk into health centers or healthcare experiences which are dignity enhancing.
We hear Prashanth Srinivas, the ITM alumnus we met in the first episode of this season.
I think that's very, very vital and important. Why do I say that? It's because in several countries, including perhaps in high-income countries, healthcare experience is not enhancing dignity for a lot of people. It's disempowering. It's transactional. It's that's at the heart of why people do not seek professional help.
Imagine you are told that you have HIV. Fortunately, medicine has ensured that it is no longer a death sentence in a lot of countries. There are also pills to treat other sexually transmitted infections, or STIs for short. What the drugs cannot do, however, is remove the stigma that society still all too often adds to the mix.
What we find is that there's still a lot of, unfortunately, doctors, nurses who stigmatize STI. So we still have patients who, who come away feeling awful after a consultation.
This is Chris Kenyon again.
Taken out of the doctor's office in front of all the patients in the waiting room and being told in front of everyone, this one has HIV, that sort of thing. It still happens in Belgium in this year.
Too many people are still stigmatized because of their sexuality or the sexually transmitted infection they have. Chris is passionate about making people not only healthy, but also happy. He wants the ITM clinic to be a safe place where people can go without fear of being judged.
Yeah, I mean, we're there for them, we're there to improve their health. We don't want to just prevent them getting STIs. We want them to live healthy, fulfilling sexual lives, and we wanted them to do that in as safe a way as possible. And then we want to be there for them if they have STIs, if they get symptomatic. We want to make sure that we can give them optimal treatment.
Tim de Vrieze regularly visits an HIV/STI clinic to get information and strongly believes in the importance of living a healthy, happy life.
Especially when it comes to sexual health, I think happiness has to be a part of the equation.
And we need to put the care back into healthcare.
There should be a big focus on, the clinical aspects of healthcare. But I think specifically for this topic, people need to be cared for. Listened to. I really have to applaud everybody. I never once experienced a judgment call or shame, or the care was provided. It was very emancipatory as well. It wasn't paternalistic, they were not like, it was very like, you have this in your hand, let's talk about it.
In the quest for a more robust healthcare system, you cannot lose sight of dignity or hidden factors like stigma or people's lifestyles. You need to involve the community and listen to them. As the COVID vaccines became more widely available, for example, a lot of communities were suspicious. In many places, they thought they were getting the leftovers, the waste from the richer countries. That didn't make the challenge of convincing the whole world to take the vaccine any easier. Let alone that you want to vaccinate remote communities like the Soliga people living deep in the Indian forest. Prashanth took on the task, but had to find the right angle to approach the problem. Prashanth has lived and worked with the Soliga community for years, but when the vaccines arrived, people were suspicious.
When we had to convince indigenous people living in fairly remote settlements that this vaccine will save your life, many of them were asking, how come that our life is so precious to save and this vaccine is going to do it?
People in our villages are dying from so many other things that are not being addressed, they said. We have been asking for roads or water or other basic things for so long, and now this vaccine is going to save our little village in the mountains. They were skeptical.
Many of us were dumbfounded. What do you say to this? How do you even respond to the fact when people are saying, I don't have roads and water, and now the COVID-19 vaccine is going to save your life? It posed a very important ethical question.
The approach had to be different. And so Prashanth's wife, Tanya, went on a big tour.
So she toured about 80 to 90 of the 148 tribal villages in our district in deep forest areas, spending a day each.
She didn't do this tour alone. She was accompanied by a full street theatre.
We worked with a folk artist called Basavaraju. So he created a whole street theatre routine about how the virus originated in China, but it wasn't their mistake, but it's now come everywhere. It's now at your doorstep. So, and he framed the vaccine as a right. So he said, others are taking their rights. Will you get left out of your rights now, just like we got left out earlier? So he framed it so beautifully through a dance drama, which was performed in each of these 148 settlements.
After the street theatre, there was a debate where tempers sometimes ran high. People were for it, people were against it. But in the end, the team achieved a vaccination rate of over 90% in the area. People took their right to get access to the vaccine.
That was a really fulfilling experience, and it really showed for us the the power of community engagement when you do it.
By getting the entire community involved, you can get extraordinary results.
Yeah, and later after that, when people ask what survives from COVID, did any of the system's lessons survive from COVID? Not much actually, but one thing survives is the Corona Mari dance. So Basavaraju continues to perform it as a reminder for tourists who still visit to our village. He still performs the Corona Mari dance, and he tells the story of how my group of folk artists helped with getting my community the vaccine.
Do we not learn from our mistakes? Is access to healthcare not a given? As Chris summarises,
well, like I say, I don't think so. No, I think we have to fight that same fight every few years. That our memory is very short. So it's something that we need to keep on fighting for.
Fortunately, the researchers at ITM and their partners fight that fight every day to give more and more people access to healthcare. It's a global challenge, rooted in global inequalities. All over the world, countries are strengthening their capacity to regulate medicines and provide access. They make real progress, so that step by step, we evolve into a world where health for all is possible.
And the results were quite frightening. We found that 27% of the medicine tested in the study were seriously underdosed.
Thank you for listening, and please join us for episode 3, where we discover that access to healthcare isn't everything. All over the world, people worry about the quality of the care they get. Yet another puzzle to solve. For more information about the Institute of Tropical Medicine in Antwerp, visit itg.be/podcast.